Good morning, ladies and gentlemen. First of all, I would like to thank as well the organizers for giving me the opportunity to come here in Vienna and share some of my thoughts on this important topic about health-related quality of life after cardiac surgery. And as the title says, it's very difficult to define what exactly these mean. The two previous distinguished speakers, they have emphasized with their leadership role and their academic role in the international literature about the role of arterial grafting in elderly, and they were dealing with very hard endpoints like mortality and morbidity. And both of them, they have contributed so significantly. Now I have to say that I will move to other endpoints which are softer, like the quality of life. Elderly is, first of all, I have to make a strong statement that although we think that the elderly is a particular group of patients, is a very heterogeneous group. So I will start my presentation with the following topics: why coronary artery bypass grafting remains a challenge, what is the transition in societal demographics, the role of health-related quality of life in elderly, what is the following cabinets, the evidence, the existing evidence, why the decision-making is problematic. I will end up with some conclusions and what is the future work that can be done on this particular topic. If we look into what exactly is the main problem that is happening in the elderly patients, first of all, we have problems with the central nervous system. We have problems with the visual and sensory systems, and we have problems with the circulatory system afterwards, and problems with the respiratory system, and problems with the with the skeletal system. So if we think about what exactly is the level of dysfunction and disability, and we think how we intervene in elderly patients, we will see that if we analyze the pathway properly, initially we have some alterations in biological markers, then we have specific disease markers that can be affected by the intervention, whatever intervention is this. Then we have the symptoms to appear, which can affect the function, and then the individual domains in health-related quality of life can be altered, with result to have an overall effect in the health-related quality of life, and there is sometimes a discrepancy between what the patient feels and what the patient reports in questionnaires. So in this particular paper that was published in the American Heart Journal in 2006, you can see that in the first 3 lines, the MI, the CABG, and the stable angina can affect the functional capacity of an elderly patient, affect the quality of life, but they carry significant morbidity and mortality compared to other interventions. So why there is elderly is a different group? The reason that is a very particular group is that it is a group that does not tolerate complex procedures, but from the other side, you expect to do long and complex procedures. So it's a paradox, because they have complexity, and from the other side, they have problems with comorbidities, and there is a problem with physiological adaptation to stress. Also, we need to point out that in the current health services system, there is quite a lot of determinants of what exactly is happening with the quality of life of this particular group of patients, because the elderly patients always, they are waiting in the pathway to be treated. The treatment always has diagnostic problems, and they delay to get the appropriate treatment, and always they end up spending weeks and weeks of investigations in cardiology wards. So I tried to identify in the literature if there is a particular definition for and why some definitions have been adopted in terms of what exactly is the elderly population. So I did a searching in the literature, and I found that the WHO definition about elderly population is age more than 65 years. I'm not surprised that they have adopted this definition because it has to do with the age of retirement. But in cardiac surgery, there is a completely different approach to what we mean elderly. Now, we have to accept that there is a transition in societal demographics, as was pointed out by Professor Buxton earlier. I don't want to extend too much towards this direction, but I would like to point out that this differentiation in the demographic transition is more evident in well-developed, in the more developed regions. And also, we have to accept that there is a quite significant shifting phase in the healthcare. We have moved from acute to chronic disease, from institutions to network of care, from a single professional to many healthcare professionals, and also the expectations and the knowledge and the involvement of the family has become very much stronger. So if we think about the disease in the elderly, we will see that there is an increase in chronic disease, there is an increase in life expectancy, and there is an increase in the number of older persons. Also, there is an increase in the number of older persons with disability. And this brings burden not only to the person itself, but in the family, the community, and the society. So there is also another challenge that more complex interventions are required in elderly patients. And if we want to emphasize what is the role of health quality of life following CABG, we have to think that health-related quality of life is a multidimensional outcome that can be separated in three different categories: physical, mental, and social. Now, if we look into what exactly is happening in coronary artery disease, you will see that the disease is a coronary inclusion or a vascular function or inflammatory state, and then the symptoms come along, which is the angina, and then there are physical, emotional, and social changes, and sometimes the patients, they report there is a discrepancy between what the patients report and what exactly they wanted life to be. So this diagram shows what is exactly the range of health status in coronary artery disease. We need also to consider that it's not only the health state that the patient is when undergoes coronary artery bypass grafting, but also we need to think that all this, the quality of life and the health state of the patient affect patient satisfaction. Recently, there has been a lot of emphasis in patient-reported outcome measures, and particularly patient satisfaction and health-related quality of life in terms of provision of quality of care, as also as a part of the quality improvement initiatives as have been reported by the American Cardiothoracic Society. Now, another point that I would like to make is that measuring quality of life is not an easy task. You need to break down what exactly are the factors that can affect the quality of life, like the symptom amplification, the personality motivation, values, preferences, psychological support, social and economical support, and social and psychological support. And also there are other non-medical factors that can affect the quality of life, as has been described in this particular model in JAMA in 1995. Now I would like to go through the evidence available. There are around 103 papers that I managed to get from the literature, but I would like to point out before I move to the elderly that this particular paper is very important, as pointed by Joel Dunning, that pointed out that there are significant predictors of poor long-term quality of life, like the smoking, Canadian state, the Canadian Cardiovascular Society grade 3 or 4, redo operation, female patient, sex, diabetes, peripheral vascular disease, more than 2 days in the intensive care, and chronic obstructive pulmonary disease that can affect the quality of life. This is a very big study that measured QALYs after cardiac surgery, probably the biggest that has been performed in UK. Also, this paper that used structural equation modeling to identify what are the factors that affect quality of life pointed out that depression and anxiety are important factors that need to be considered when we measure quality of life. In a previous paper that we performed a few years ago, we identified that it's not only the anxiety and the level that the patient has when the measurements are taken, is also the type D personality that has been described by Denollet, that has a significant effect not only in the physical status of the patient, but particularly in the mental status of the patient. This can be affected 5 times in terms of if we take into account the personality of the patient. This also, it was in a population that was not elderly, but significant amount of patients in this study were above 70. Now I will move to the main part of my presentation, which is what is the role or the effect of coronary revascularization in quality of life. And you can see that there are significant reports in the literature that have pointed out that octogenarians can undergo cardiac surgical procedures at a reasonable risk and show remarkable improvement in their symptoms. Elderly patients benefit from improved functional status and quality of life. Another paper by the Journal of American College of Cardiology demonstrated that 1 year health-related quality of life was similar to younger patients, although they demonstrated slower recovery. Also, longer follow-up, 4 years, demonstrated in this particular paper in the European Heart Journal by Graham, demonstrated that the 4-year combined benefit of survival and health-related quality of life. And the conclusion was that elderly patients undergoing revascularization have better health status 4 years than those that in the same age group don't undergo revascularization. So these findings suggest that age should not deter against revascularization given the combined benefit in survival and quality of life. Also, another question is what is the role of off-pump in health-related quality of life? This is one of the studies, the most important studies that has been undertaken, and this is by a Denmark group, and it was demonstrated that there is no effect of off-pump or on health-related quality of life in measurements that have been undertaken at 3 months post-op. In a different study, there is measurements in quality of life 18 months after coronary artery bypass grafting. There is some improvement up to 6 months, but they demonstrated that this returns to the preoperative level at 18 months. Another important point that needs to be taken into account that the support that these patients need is quite high in terms of percentage of people that they require support is about 2 in 3 in this group of patients. So after all this searching, I identified only one study that is on the way, is only one RCT that deals with the impact of avoiding cardiopulmonary bypass during coronary artery bypass grafting in elderly patients. This is from a Danish group. And I have a little bit of problem with this trial, which is on the way, because if you read carefully, it demonstrates that the trial surgeon's requirements is to the surgeon to have at least performed 25 on-pump cases and 25 procedures. In some work that we have performed at St. Mary's with trainees and consultants performing this operation, when a few years ago 55% of the cases were undertaken by trainees, we demonstrated that the learning curve for off-pump is around 67 cases. So you can imagine if you put 25 as cutoff, what exactly is going to be the result of this particular study. And we need to learn from trials that, like the CHRIST trial, which is on the way, how you can incorporate learning curve points within the model of a trial. Now, I will move to the decision-making and why this is problematic. I think this is very problematic because we mix things like comorbidity, disability, and frailty. And also, sometimes we ignore the effects of frailty, especially in the VO2 and the strength and the power and how these patients can go through an operation like coronary artery bypass grafting, even this operation is minimally invasive operation. So if you think about the relationship between physical and psychosocial frailty, you will see that there is, if you have less physiological reserve, the higher the possibility to require high psychological support, psychosocial support. So you can see that these two parameters, they define who is frail and who is not. Also, with frailty, you need to accept that there is a domino effect that can be demonstrated with physical decline, with social breakdown, with mental decline, with polypharmacy, and all this can affect the psychological and the physical component of an elderly patient. Now, what are the factors that can affect our decisions? The factors are patient-related, disease-related, and of course the surgeon needs to make up his mind who is the appropriate candidate for an operation. Another important aspect is that why quality of life outcome has not been taken very seriously in our clinical practice and in our decision making. But it is obvious that more work needs to be done in terms to define what a standard a change in quality of life of one standard deviation or two standard deviations can have in the current clinical practice to translate these messages in valid and important points in decision making. So this paper has demonstrated these problems and has pointed out how much work needs to be done to identify what this clinically means. Now, I would like to also emphasize that according to the current knowledge, we can classify our patients not only according to the age, but we can classify them in healthy older persons, in early frail people with low risk, with chronic disease, in medium risk, with mild to moderate disability, high disability and complex systems on integrated care. This is a very bad group to operate and to offer quality of life, and also the final group, which is the end of life of care. I don't think surgery has an important role in this group anyway. So I will end up with some conclusions. First conclusion is that most patients may have transient decrement in function 1 month after coronary artery bypass grafting. Second is that health-related quality of life is not homogeneous for the physical and the mental dimensions after coronary artery bypass grafting. There is little high-quality evidence for the benefit of off-pump health-related quality of life in elderly. I don't disagree that can be a potential benefit in terms of mortality and morbidity, but in health-related quality of life, the things are, as you can see, the evidence is very poor. The other conclusion is that individualization of revascularization choices for the elderly can optimize the management of this particular group. Preoperative assessment of health-related quality of life is an important predictor for postoperative outcome in general, and use of new technology can alter our considerations about the complexity of measurement and assessment of postoperative health-related quality of life. So the main question now is what is the future and how we can change this approach to the health-related quality of life. If we think about aging population, as I mentioned earlier, you need to think about a balance between acute disease and chronic disease. And what we use at the moment are diagnostics that they give only a snapshot of a patient's health. So what we have performed at Imperial College is that we have focused in new technology and how this technology can be applied to measure quality of life. And we use particular devices that have the size of a Bluetooth that you can put in your ear, and you can check 7 to 8 parameters, physiological parameters, that can be transformed to this graph, which is basically a multiple waves that can be analyzed properly with a particular software. And you can, with principal component analysis, you can identify what is the status of a patient and what is his functionality during the postoperative period up to 1 month. And this can make the whole monitoring to transforming to a continuous monitoring process. And you can see here in the pre-op status has a particular measurement, and you can see during the first, the second, the third, the fourth, and the fifth day how the patient goes towards back to the preoperative functional line. And this can be measured objectively. And also, we can use tools that the patient can interact through the the computer systems available and can be even put in a Google, and patients can self-monitor themselves in terms of achieving their targets in the post-operative recovery. So if we move now to the health policy and well-being evaluation, you will see that what is missing at the moment is that we value the well-being through, we need to value the well-being through the patient journey. And also we need to think how we can join the patients and the carers' well-being. And this can be done only if we break down what exactly we measure from the pre-op level, what are the expectations, what is the anticipated experience, and then we move to the immediate post-op clinical outcomes, and then to the long-term clinical outcomes, and get the information about how exactly these patients feel following an intervention. And in this direction is a model that has been popularized even by Barack Obama in the States about behavioral economics and how behavioral change can affect well-being. Now, what is the new, what is the way to change towards a good direction in cardiac surgery in the elderly group to achieve better health-related quality outcomes is that we need, first of all, to increase the infrastructure problems, to resolve these problems, to achieve behavioral change, and to, of course, we cannot achieve all this if there is no enhanced income to this particular group of patients, which is the weakest part of the society. Now, if we want to really to take a message home here, is that we need also to understand what exactly, how complex is the problem and how we can approach it with analyzing the contextual characteristics, taking into account perceptions and behaviors, and then translate this into the current clinical practice. Also, we need to understand that it's important to measure health-related quality of data in the beginning of the flow in the patient's journey, so we can use these tools as patient monitoring and risk assessment and stratification, and then move this information back into the point of care and come up with conclusions about guidelines and new discoveries in coronary revascularization in this particular group. So, in conclusion, if we want to take some message about the health-related quality of life, we need to assess the mental status of a patient, the emotional status, the independence, the physical activity, the compliance with the medications, and the procedure comprehension. And as most of the people know, it's not good enough to say that we apply evidence-based medicine without putting a strategy. And the answer to this is that we need to act with a proper strategy in order to achieve patient-based medicine rather than evidence-based medicine. Thank you very much.
Thank you very much. We will have the discussion after the next presentation.